We're so pleased to be having Dr. Jean Marie McGowan with us from Sanford Health. She's going to help us bust some of those myths of menopause, and I can't wait to visit with her more about this and hear her presentation. So for more than 60 years, AARP has been working to improve the lives and empower those 50 plus to live their best lives. And part of life for women is menopause, and it's just a topic that does not get discussed near enough. So today, that's exactly what we're going to do. So welcome to all of you, and I want to especially now welcome Dr. Jean Marie McGowan from Sanford Health in Fargo. Dr. McGowan is an internal medicine physician with the Sanford Women's Specialty Clinic, and we just welcome you. I tell you, you have such a great background, including being torn between pursuing a musical career on Broadway or medicine. So please tell us more about yourself, Dr. McGowan.
Well, first of all, thank you for having me. This is so exciting that I get to talk about this and reach so many people in North Dakota. So thank you to the AARP for putting this on and inviting me to speak today. I am originally from Brooklyn, New York, and I always was interested in women's health, always wanted to be a doctor, but didn't know exactly what capacity, or the capacity that I thought I'd be in women's health has really changed over the years. And I'm so glad that my path has led me to menopause, because it's really an under talked about issue. It's barely taught in medical schools and very little in residency. So, you know, I had to go for extra training. And once I did and see women for this, they're so happy that I understand what's going on or can clear things up and really help out in different ways. So it's been really rewarding. And as far as the music goes, I mean, I love singing. Right now, it's just limited to the shower, the car. But you know, that part it'll always be a part of me. And I have a little dog named Minnie. She's very sassy, and that's my family here in North Dakota. So I've lived here now for 10 years and really enjoy it.
Oh, that's fantastic. Well, I'm a dog lover too, so when you mention dogs, that my ears perk up. So very good. Well, we're eager to hear more about this, and I'm thrilled too, because you were telling us earlier that you just came back from a conference on this very topic. So I'm going to turn it over to you, and we're going to get after your presentation now, and we'll have you take it away, Dr. McGowan, and we'll come back a little bit later and cover some questions after you're done with your presentation. So
perfect.
Thank you very much. It's all yours.
Thanks. I'm going to share my screen here.
Perfect.
Please let me know if there's an issue with this.
Yes, I see your screen.
And I'm gonna, can you see the slideshow?
Yes.
Okay.
And I'm seeing your second slide as well.
Okay, so let's change the screen here.
That's okay.
Okay, I know how to do it. There we go. Better?
Yes, perfect.
All right.
Thank you.
So, yes. So as I was introduced, I'm Jean Marie McGowan, and I am the physician lead at the Sanford Women's Specialty Clinic. I'm an internal medicine physician by trade, so I only see adults. And then I went for further training on menopause management through the North American Menopause Society, which is a medical organization consisting of many different medical providers in different areas, whether they're gynecologists, oncologists, internal medicine physicians, family med, psychiatrists, dietitians. So really a huge group of people. And we make sure that we provide the most up-to-date, scientifically based, evidence-based medicine. So the objectives, I'm going to try to do my best to fit everything I've learned into 30 minutes. As I was saying, I went to a 4-day conference over the weekend, and so 30 minutes, I'll try my best to stay on task here. So I want to define menopause and its related terms, explain some of the physiological changes, and then review some treatment options. I'm not going to go into the weeds on treatment options just because every woman needs a different kind of approach. It really should be individualized. I have no financial disclosures. These are some of the resources. So the North American Menopause Society has a wonderful website. I've used their textbook, but they have tons of articles for patients and podcasts, videocasts. I also do love the AARP resources that are available for you. Many of them have been created by my mentors in NAMS. So, and then the American College of Obstetrics and Gynecology, or ACOG, they have guidelines as well. So I really do use guideline medicine. So I often hear this in my clinic: your hormones are out of balance, or, you know, I'm just hormonal. Well, of course you are. You need hormones. We all have hormones. We have different kinds. And they're not out of balance, they're just shifting. So it's trying to get to a new normal. Menopause is very normal. So let's just start with the definitions and changes. So menopause, it's, again, normal, natural event defined as the final menstrual period confirmed after 1 year of no menstrual bleeding. And sometimes this definition doesn't apply if you've had a hysterectomy, but essentially it is the permanent cessation of menses. So it is a huge shift. It's usually a milestone of midlife health. It's the end of being reproductive, and it's an opportunity really for reassessing your health and your health goals. So natural menopause is what occurs spontaneously for most women. The average age is around 52 in the US. Different ethnic groups may have earlier or later onset. Premature menopause is defined as menopause before the age of 40. Early menopause is before the age of 45. So there's different definitions. Premature menopause, it's not very common and affects about 1% of women. And that's usually linked with premature ovarian failure or insufficiency. So induced menopause is usually through surgical means, and that means that they're taking out your ovaries, and we call that an oophorectomy. When you have your uterus removed, that's considered a hysterectomy. So if you had both your ovaries and your uterus removed, it's called a bilateral salpingo-oophorectomy with hysterectomy. And that's, the salpingo stands for the tubes that tie the ovaries to the uterus. So if your ovaries are removed, you will go into menopause. If just your uterus is removed, it's not necessarily that you're going to go into menopause if your ovaries are still present. Chemotherapy and pelvic radiation are other causes of premature menopause. So perimenopause is defined as the time around that final menstrual period. Now, we won't know exactly when that is until you've had 12 months without having a period. So it's what we say a retrospective diagnosis. But perimenopause is that transitional period. So it's that the first 2 years before that final menstrual period and the 2 years right after. This is the time when the most symptoms are present and they're the strongest. The symptoms could be gradual or they could be acute. But usually they're temporary. So postmenopause is after that final menstrual period, or when that, after if you had your uterus removed, it's when the ovaries stop working. And it's important to keep in mind that at this age, you know, the average life expectancy for women is about 82 years old now in the US. So you're living a third to half your lifespan in this post-menopause phase. That's a huge chunk of your life. And like I said before, it doesn't get spoken enough in medical schools or medical training. So you really have to make sure that you're going to somebody who understands these changes. So, and not all midlife symptoms are because of menopause. We're aging at the same time. So every year we get older, things get a little bit stiffer. You know, our certain risks for cancers or heart disease go up. So it just happens to coincide. But there are some things that we definitely can blame it on menopause. So estrogen receptors are almost everywhere in the body. There's a few exceptions, which I'll go through. And it's not really important that there's two different types, but they are not just in the ovary. That's where it's like the biggest boss, or most in charge, but they're in the breast, they're in the blood vessels, they're in your eyes, your ears, your skin, kind of everywhere. So estrogen has many complex beneficial and also deleterious effects on the body. So once we lose that estrogen with menopause, we're going to see changes on these areas. And there's no one universal menopausal syndrome. So not every woman presents the same way. So the classic symptoms and signs are, one, change in cycle. So this is often during perimenopause. So menstrual cycle patterns will change, hot flashes or vasomotor symptoms, vulvovaginal symptoms or pain with intercourse, which is dyspareunia, sleep disturbances. And then there's also some cognitive issues and maybe mood changes, and then just the general other changes, which I will go through. So menstrual bleeding changes. So changes in both menstrual flow and frequency are common. So it could be lighter, it could be heavier, it could be longer in duration, or maybe shorter in duration. You could maybe skip a few periods. So it's important to keep in mind that, like I said, the average age of menopause is 52, and women might have most severe symptoms at 50, right, 2 years before. But we can see some women have symptoms 10 years before that final menstrual period. So we can start seeing symptoms in your 40s, and it makes it really unpredictable. So tracking your periods can be helpful. And there's various different ways to treat this abnormal uterine bleeding if it becomes dysfunctional enough to cause you other issues like iron deficiency, anemia. Fertility changes, right? So we're going from being reproductive to post-reproductive phase. So fertility starts weaning in our mid-30s before we get into that perimenopausal stage. And by the age of 45, we still could get pregnant, but the risks are pretty high. There's a risk of spontaneous miscarriage by 50%. The risks of having a child with a congenital anomaly increases. And there's still cases where women get spontaneously pregnant 1 year after their final menstrual period. So family planning and contraceptive could be very important if you are still sexually active and depending on what your goals are. So let's talk about hot flashes. So these are called vasomotor symptoms in the medical world, but hot flashes are fine. In Europe or Australia, they call them hot flushes. Sometimes they're called night sweats when they're at night. But hot flashes, what's very important is that they have a very classic definition. So it's not just I feel hot all the time. That's a different story. That could be from medications or thyroid issues, or I don't know, you live in Florida, different reasons. This hot flashes are very classic. So they're transient episodes with a very increased warmth, usually on the upper body, face, and head, but they can be all over. So frequency, this affects about 75% of perimenopausal women in the US. The number of episodes vary. You can have few to multiple times a day. And the highest occurrence, like I said, is those 2 years pre and post that final menstrual period. So, and we do know in certain ethnic groups, like Black women tend to have a longer span of hot flashes, both before and after their final menstrual period. But in certain cultures, like Asians, have less. As far as intensity goes, it's severe in about 10 to 15% of women. I mean, these women are having them every half hour to hour, and they're just drenched. I've seen various different rates of intensity. It does often go away after 3 to 5 years from that final menstrual period, but there is that 10% of women which persist. And some of these women, we have some risk factors that we can associate that with. Okay, so so this is just a nice diagram that I liked, showing what happens. So the core body temperature slowly increases, and that increases blood flow to the skin, and it also increases your heart rate. The intense feeling of heat with reddening of the upper body occurs within 1 to 2 minutes, so it's not a long period of time. Then your heart rate peaks, and you got increased skin blood flow peak. And again, this happens within 5, 10, 15 minutes, no more than 15 minutes. And then within 2 minutes, your core body temperature drops 2 degrees like this. So very severe. Usually women describe chills because they've just been sweating and so hot, and then all of a sudden their core body temperature drops. So this is what happens. Why does this happen? Well, we don't fully understand the mechanism as to why this happens. We believe it has something to do with endothelial dysfunction, and that means that there's a vascular issue. So as you see, it does increase heart rate, right? So your blood vessels are involved. And we do know that there are certain conditions that women, if they have these conditions, we see worse hot flashes. And those many times are preeclampsia, eclampsia, gestational hypertension, gestational diabetes, chronic hypertension, migraines with aura, not necessarily without aura. Usually that aura part is a vascular dysfunction, at least that's what we believe is occurring. And then there are other things too. So smoking can make it worse, stress, alcohol, hot drinks, caffeine, having a higher BMI. There are certain medications that could bring on hot flashes. So aromatase inhibitors are common drugs that are prescribed either to prevent or to treat breast cancer, and a lot of antidepressants, which I'll get to hopefully later, as to why they could potentially be helpful too. And what's really interesting is that the level of estrogen has nothing to do with the intensity of your hot flashes. So testing those hormone levels aren't really going to help me. I need to just see you. And seeing a hot flash, I've seen many, are very impressive. So I believe you when you say you have this. Oh, and I'm sorry that this picture is cutting off a word, but these are the vaginal changes that occur. So at menopause, when we're losing estrogen, the mucosa of the vagina is just a little bit less resilient. It gets thinner. You can see it's not, it gets thinner and it's not as rugated here. So it's just flat. So this makes you more prone to bleeding. It also changes the pH of the environment. So you go from being acidic to more alkaline. And this also contributes to a change in the microbiology, the microbiome of the vagina, which then can contribute to having more infections or bleeding. So some symptoms could be dryness, irritation, itching, pain with sex, and this is experienced by 10% to 40% of women. Now, unlike the hot flashes, which can go away over time, the vaginal dryness is it's progressive, and it's unlikely to resolve on its own. So this one doesn't get better. This one, you're going to have it. And some women don't have it so bad, they don't notice it, and some it gets progressively worse to where they're really uncomfortable even sitting. But there are treatments that we have for this. And sometimes we call this genitourinary syndrome of menopause, so GSM, because we also have urinary issues that start coming up around the time of menopause. Now, there's some, on this conference that I just went to, we're questioning if it's really menopause that caused the change in urinary issues. And maybe it's more of an aging issue. We're not entirely sure just yet. So as of now, I'm saying it's related to menopause. And this affects up to about 60% of women have leakage or incontinence. So other complaints would include frequency, urgency, burning, and sometimes blood in the urine, which may be from that vaginal dryness. As far as sexual health goes, libido or desire decreases with age. It's not necessarily a menopause issue. again, there just happens to be a lot of the same issues during menopause, the same aging issues that happen around menopause that play a role. That vaginal dryness, if sex is painful, your body's not going to want it. And so therefore your desire is not going to be as high as it was before. There are ways to get around that. So, don't sit there, you can talk to physicians about this or provider. And remember that change in pH can make you more prone to getting a sexually transmitted infection. So heart disease, there is a menopausal change. Remember, so especially those with hot flashes that have the worst, those are the ones that I worry the most about having vascular issues down the line. So heart disease, it is the #1 killer for women after the age of 65. So this is a major concern. And symptoms present differently than men, or I challenge this, women describe their symptoms differently than men. So a big key thing to keep in mind for all women's health, whether it's menopause or otherwise, is that the medicine, the technology we have, the guidelines and the textbooks were all written for old white men primarily. And it wasn't until later that they started expanding their knowledge. It wasn't until the 1990s that women were even included in significant numbers in cardiovascular studies. And you can thank Barbara Streisand for donating tons of money for that. And it didn't even become a law that research needs to include women in the research population until 2014 or 2016, which I think is ridiculous because I graduated medical school well before that. So we're coming a long way, but keep in mind we still have a ways to go. And so our textbooks still say that classic heart symptoms are basically symptoms that men report and women are atypical, which is really not the truth. Osteoporosis is another big issue around the time of menopause. So, here are two very nice pictures that kind of show the change. A key thing is that our bone density kind of peaks when we're 20 to 30 years old, and then it slowly goes down. But when we hit that menopause transition, that bone loss really accelerates. So that's a major problem, and bone fractures are a major issue, and it affects women way more than men. Dental changes. So dental changes have a lot to do with osteoporosis. And so for each 1% per year decrease in the whole body density, bone density, the risk for tooth loss quadruples. So this is huge. So make sure you're getting those regular dental exams. Headaches, usually headaches can get better after menopause. So a lot of times the headaches might get worse around that perimenopausal phases when we're having such fluctuations in hormone levels. But generally speaking, they will get better. There, again, is that subset of women, that 10%, where we see like migraines either persist or get worse after menopause. Hormone therapy may have a place. It really depends on the woman. Gastrointestinal changes. So the GI system, so mouth to the esophagus, to the stomach, to the small intestine, to the colon, there are no estrogen receptors there. So this is the one place where menopause doesn't really have a change. However, there are other issues that may cause gastrointestinal problems. So stress, not sleeping well, if you had some major dietary changes, that obviously will affect your bowel habits. And what was really fascinating at this conference last weekend was that it's looking like estrogen receptors, when we lose the estrogen, the cells that surround the gut and the colon, the intestines where we absorb nutrients, get a little bit more leaky. So not only are we losing some nutrients, but we're also now getting some inflammatory markers circulating into the body, whereas before menopause, estrogen would have blocked that. So we really are what we eat. So anti-inflammatory diets or Mediterranean diet, Whole30, those are all pretty good diets to follow. Skin changes, there is a decrease in collagen in the first 5 years after menopause, and then it declines more often, and that's why there is such a change in skin, and there's a huge number of estrogen receptors there. Hair changes, we do get female pattern hair loss where it's more thinning on the crown or the top of the head. And of course we get those rogue chin hairs, they're so thick and we gotta pluck them, and it's really annoying. So that is because of the shift of estrogen to testosterone ratio. Eye changes, we even have estrogen receptors in our eye. So we will get more dry eye, blurred vision, tired eyes, swollen and reddened eyelids. And we do see more cataracts in women, but we're not sure why. That's not necessarily with menopause, but there's just a higher prevalence in women. Hearing changes. So menopause does trigger some hearing loss. So make sure you have a good baseline hearing test. Good hearing helps keep good memory. More men than women suffer hearing loss, but it's still an issue. Women are not immune. And then the one I get most often in my office is, Doc, I keep gaining weight. I turned 50 and I can't get it off. Unfortunately, I don't have great news when it comes to weight and menopause. We do see an average weight gain around 5 pounds, although I've heard anywhere from 20, like up to 20 pounds almost overnight. And it's mostly related to aging and lifestyle. However, I know that's not always true. I know there are many people who eat very healthy and exercise regularly and are still gaining weight. So the main thing to keep in mind is that the body shape changes. So this is what happens. We go from having this pear-shaped or gluteofemoral fat, aka a big butt, to now this apple shape where we get more of the fat in the waistline, and that's where the fat coats the organs, which then makes us more insulin resistant. So this I know is a big concern. It does set women up for more health problems, both heart and heart-wise and diabetes-wise. And so it is important to address. That being said, we do know that the weight gain with menopause on an evolution level was probably so we don't have osteoporosis breaks. So weight on our bones does protect them from breaks. Obviously it's not foolproof, but this is probably why we gain weight around this time. There may be other reasons, but we don't know why. So, and then cancer, menopause does not cause cancer or any cancer risk. It's just the aging risk. So there are some issues with sleep and mood that can occur. And I don't have to tell you what stresses you out at this time in your life. There's a lot of things going on, and that does play a big role into sleep, but menopause itself can change sleep pattern. But there are the other things. So even when we control for bathroom breaks and sleep apnea, pain and depression and hot flashes, there are still sleep changes that we see around menopause. So that's very common. Cognitive changes. This one is a little bit controversial at the moment. We can't seem to agree on whether hormones help or harm cognition. There's mixed studies. But if the brain fog symptoms and memory changes occurred right around that final menstrual period and very quickly, chances are those will get better also very quickly. So there seems to be a transient brain fog that happens around that perimenopausal time. As far as mood changes, you're having big fluctuations in estrogen and progesterone, testosterone, so you're definitely getting mood changes. Some women are more affected by this than others. And so women with a history of mood disorders before menopause, those who've had a history of baby blues or postpartum depression or anxiety are at most risk for seeing a flare of their mood disorder or a recurrence. And This one, sometimes we see get better, sometimes it doesn't, and it may persist. So it really depends. Again, there's a lot of things going on at this time in your life. So there's a lot of different factors. So menopause you can blame some of it, but not all of it. And as far as clinical evaluation and counseling goes, so generally speaking, most women view this as a positive change. And we do see that women who have very negative views on menopause actually have worse symptoms than women who don't. And we also see worse symptoms with women who have a lower economic status or a lower level of education. And that is for various reasons, obviously access to healthcare and whatnot. But this is an important transition. So to confirm menopause, usually we just need to take a history and sit down with you. So how old are you? When was your last menstrual period? Or when did you start having symptoms? We can test hormone levels. However, most of the time it's not necessary. Truly, it's not. If you're having some other symptoms that don't sound menopause related, we might check something like a thyroid or blood counts. But generally speaking, it's not going to tell me anything. I know they're fluctuating, and the labs are inconsistent. So if you get tested at this lab here, it's different than the lab across the street. There's different reference values. You have to get it done exactly at 8 a.m. There's just too many variables, and it's really not going to change our treatment. We might test FSH or anti-Mullerian hormone, AMH, because that might tell us what's your chances of getting pregnant. I might also do this for women in their 40s who start having symptoms and have something like PCOS, polycystic ovarian syndrome, where they tend to have irregular periods to begin with. So I generally don't recommend hormone testing. There are exceptions. So who do you talk to? So like I said in the beginning, not everybody gets great training in medical school or in residency. I've gone to the NAMS conference every year for the last 5-6 years, and I make sure I come back to my colleagues to present on what are the big changes. I also teach residents and medical students, and we've been really pushing to have more knowledge on menopausal healthcare, cardiovascular disease in women, pelvic floor dysfunction. So a lot of those issues. So you want to make sure you're going to somebody who understands menopause and is not scared of hormone use. So this is, again, the North American Menopause Society's website, so menopause.org. They have tons of information for you. As far as menopause management, it looks like I'm not going to have time to delve into this very much. And like I said, it really should be individualized for each woman. So, there are some women, if you're young enough, where oral contraceptive, those doses might be appropriate, but generally speaking, hormone therapy for menopause is usually a lower dose. So when to stop oral contraceptives, I usually stop at around 50, which is that typical close age to menopause. And we might go to a lower dose of estrogen if you need it. For hormone therapy, there are a few different things to keep in mind. Estrogen therapy, this is unopposed. This is for women who've had a hysterectomy. Estrogen and progesterone, these are for women who still have their uterus. And then there's bioidentical hormone therapy, which is a very nice marketing term. So bioidentical, really, it's truly just a marketing term. So we have two types of estrogen. One we call, quote, bioidentical. The other is conjugated equine estrogen, so it comes from horses. So that's why the non-horse one is called, quote, bioidentical. There are FDA approved products, but a lot of times when we say bioidentical, it's usually referred to compounded hormones, which are not recommended because they are not being regulated on a uniform basis. So the only reason for hormone replacement therapy for women who naturally enter menopause is for vasomotor symptoms. This does not include women who have early onset menopause before the age of 40. those women, for whatever reasons that they needed their ovaries removed or they lost function, those women need to be put on estrogen in order to protect their bones and their heart. But for women who go through menopause in a natural way, hot flashes are the only indication for hormone therapy. Now, we can use it if you have that genitourinary syndrome in menopause, where we can't treat it with topical medication. Osteoporosis, it's used for prevention, not for treatment. And that's if we can't use other medications to prevent it. But it's not used for heart disease prevention. It's not used for mood, and it's not used for brain fog. We can't prove that these things consistently improve in women. It's not going to necessarily help weight gain. It's not necessarily going to help migraines or vision or some of these other things, because there's nothing like what we say endogenous estrogen. So the estrogen that we're born with is never quite the same as the one that comes from the lab, from the compounded pharmacy. It's just not the same. So we cannot use those our hormone therapy for those purposes. We typically don't like to use this more than 5 to 10 years. Tapering versus stopping abruptly, neither way. There's no data on which is better. And then I typically like the patch better just because, or topical, because it bypasses the liver and there's less of a blood clot risk. So this is contraindicated in women who've had a stroke, a blood clot, or a heart attack, and those with breast cancer, if you're a smoker. And migraine with aura is not an absolute contraindication. It's a what we say a relative. So it's something, if there's a benefit, if we know women had less migraines when they were on birth control, then they would benefit from this. So there are concerns about cancer risk, which again, we're kind of get into the weeds about it. In heart disease, it's very controversial, but it can be beneficial. There is the black box warning that it can cause endometrial cancer, breast cancer, heart disease, maybe dementia. Again, that dementia one is very controversial at the moment. And it came out of this WHI study, the Women's Health Initiative, which was a huge study back in 2002. And because the media let it leak out, the preliminary data analysis showed that hormone therapy was linked with heart disease. Every woman was taken off hormone therapy, which was unfortunate because when they broke down that analysis further, it showed that women who were started later on hormones, past that 5 years out from that final menstrual period, those were the ones at risk for heart disease, not the ones who started it around the time of menopause. So that's a whole nother talk. Vaginal estrogen does not cause cancer. It can be expensive. I know that. I don't make the cost, and insurance companies do. I'm sorry. It can improve pelvic muscle dysfunction. It can reduce urinary tract infections as well. There are non-hormonal treatments for hot flashes. Really, we are what we eat. So having a good diet, exercising regularly decreases the frequency, watching how much alcohol we use, not smoking, sleeping well is important. And there's various ways to get around this. Compounded hormones are not approved. Testosterone replacement for women is also not approved in the US. And as an internist, I worry about the heart disease. I've seen many adverse cardiac events on inappropriate levels of testosterone. Black cohosh, it's a supplement over the counter. It might work, it might not, probably won't. But if you don't have a reason not to try it, you could just let your doctor know that you're taking it. Some of these supplements do interfere with the current medications or could cause long-term problems. Antidepressants, some of them really do work for hot flashes, and that's because the thermostat of the brain, the hypothalamus, has a lot of serotonin receptors. So some of these medications can make it worse, some of them can make it better. And there are a few other medications that we might use if we can't use hormone therapy or if it's insufficient. I'm not going to go into this. So I did kind of touch on the other benefits to HRT. So I'm just going to click, 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 click. All right. So I think we should get to our questions if that's okay with everybody.
That sounds just fine, Dr. McGowan. That was a lot of really good information, and I know you've got a lot to cover, so very interesting. One of the things that you talked about was incontinence and leakage and things like that, and so, you know, Kegels, are we just going to have to do them forever? Is that kind of how it works?
It is so much more than Kegels. So pelvic muscle function, yes, is very important. There are some women who do too many Kegels, and that makes their pelvis hyperreactive and can cause a lot of urge symptoms. But sometimes it comes down to, are we drinking too much water, too much coffee, too much pop? Any pop is too much pop. It's just, there's no benefit to pop. Unfortunately, you know, moderation, okay? You gotta live. But generally anything that's not flat water can irritate the bladder, make you more likely to leak, or you know, I don't want you drinking your body weight in water. That's not a good idea. That I don't know who started that, but that's not advisable. You can drink too much water and cause health problems. So if you do feel thirsty all the time, whether it's from your meds or certain things, lemon drop candy can actually help that. There are other things that affect pelvic floor function too. And that I could spend another whole hour, 2 hours on as well. I'm happy to come back.
Sure.
Because it does affect 70% of women. And what I don't like is that the media and society has said, oh, this is normal. You've had kids, you're of a certain age, this is going to happen. Okay, but there are things that we can do about it. So it's not just about buying pads or Depends or those poison, you know, certain products. There are things that we can do. Physical therapy is first line, and you know, you have to find a pelvic floor trained physical therapist, and it is very helpful. I have women who go to 1 or 2 sessions and they don't have problems ever again. I have women who need more of that, or even medication or vaginal estrogen. So, you know, there are options. So you don't have to pee your pants. There's no, you know, there are things you can do. So don't accept that society says it's normal.
Yeah, good comments. And it's funny how your body's so smart. You come in the house and it's like immediately like the bathroom, you know. I don't know. That's kind of I'm just being honest here. I'm a 59-year-old woman, so I guess I can say that.
Yeah, that's a very fascinating, it's what we call the key and door sign. The bladder is kind of like a dog. It uses triggers. So that opening your door, it knows you're going to go to the bathroom right after. So it gets too excited, and so it starts leaking beforehand. That's what happens. Same thing with if you wake up at the same time at night, every night, and it's to go to the bathroom. That's again, your bladder's just conditioned to do that. So to shut down those cues, you do some of those pelvic floor exercises, some deep, slow diaphragmatic belly breathing, and you slowly walk to the bathroom if you still have to go.
Very good, very good. Well, that sounds like another really good topic to explore a little bit more for women. So, so one question I have too is, you know, is this a hereditary thing? Like, for example, do women kind of replicate how their mothers experience with menopause? Is that
That's a great question. So oftentimes, yes, we do see similar patterns in families. So usually women tend to go into menopause around the same age. They tend to have the same severity of symptoms. Not all the time though, because like I said, there are those issues, like if you're not smoking, you know, the person who smokes will have worse symptoms. You know, so those are different things. And sometimes it's hard, right? Hysterectomies are a very common practice for various reasons. They fall in favor, they fall out of favor, whatever the reason. So sometimes women don't know, like, oh, my mom had a hysterectomy at like 30. I don't know when she would have gone through it. And so we sometimes just try to figure it out. It's helpful information, but it's not necessarily going to change what I do. Another thing to keep in mind is that a family history of breast cancer, heart disease, blood clots, or stroke are not a reason not to be on hormone therapy. So unless it's only a personal history of breast cancer that we wouldn't do it, a personal history of blood clots. But it is worth talking about your doctor if that's still a worry for you. So the estrogen alone therapy, like if you've had a hysterectomy, can actually lower your risk of breast cancer. So it might be even beneficial to be on hormone therapy for you. So again, that's why I didn't dive deep into the treatment options, because it really is such an individualized process.
Good. Well, that's interesting. Another question we have here too about dryness and sex, and are there certain lubricants that might be better than others and things that people can use that might be helpful?
Yes.
And you probably can't like endorse, but you know, there are some, I would imagine, that are better than others.
There are. So the problem is that these brands don't advertise the pH or how many additives there are, like we call it osmolality. So how much additives make it different than water. So we want the most natural pH for the vagina, and we want the least amount of additives. So there are certain brands that I do recommend because they have that natural pH. They have that low additives. There are also natural things like coconut oil. So that's not a brand. You know, that's in your kitchen. It's in your grocery store. A little bit goes a long way, and it can be used as a vaginal lubricant or a moisturizer. So there are vaginal moisturizers. Not a lot of people know this. I didn't know it until I started doing this. But just like you moisturize your face every day, the same principle applies. So you would use those on the non-vaginal estrogen days if you're on estrogen. Yeah, I guess I won't go into brands unless I can say what my patients have liked, but that you can always email me or.
Sure. Well, very good. That's interesting. And yeah, and good to know that there is relief out there for people, and, you know, something that will help and you know, keep people from feeling pain and kind of rejuvenate things maybe a little bit too. So
Yes, there's definite options.
Yeah, excellent. So are there women that just don't experience much in terms of symptoms at all? I mean, or it seems like most of us do or did.
Right. Yeah. I mean, there's very lucky women who have one hot flash and they're done. But like I said, every woman has to go through this stage, you know, from being reproductive to non-reproductive. So every woman will go through it. Now, women don't talk about it, and it's because society has taught us that we shouldn't talk about it, right? Our problems are not worth talking about, which is complete baloney, and everyone knows that here. Thank you for having me on. And we do know that there are certain like cultures which also talk about it less. But that being said, new data is coming out that too, we're breaking down those cultural norms. So what we thought was common for certain groups is actually maybe not that common. So it's really an individual process. So I think it's just important we, you know, encourage our friends, talk up about it. And by talking about it yourself, you know, that helps, you know, open that door for that conversation.
That's great. Yep, that's right. And having this conversation is just part of that. We have another question. Why does it seem like there are cravings of carbs during this time period in our lives?
Yeah, so I can't necessarily say this has to do with menopause specifically. There are some links with estrogen changes and how that affects the insulin and insulin production, and then insulin has an effect on glucose levels, which then affects our cravings. So it's a long long pathway. So I can't say it directly affects carb cravings, but we know that when you eat carbs, especially the processed stuff, there is something addictive about it that happens in our brain. And I think it's like the dopamine spikes that happen. So it is an addiction. So once you cut that out or cut it down, your cravings will go down as well. There are certain medications that can really help with that if they're indicated and appropriate for you, like metformin. So that's common. There's some newer weight loss meds too that definitely help with that. But that's a whole nother conversation. But good question.
Yeah, thank you. Well, that is what we have for questions right at the moment. And I'm going to give you a chance to share any other final comments that you might have, Dr. McGowan. In wrapping this up, this has just been fabulous.
So I think I just really want to stress, you want to go to somebody who knows what they're talking about and knows the treatments, truly understands them. Because like I said, that 2002 WHI study on hormone therapy really changed many physicians' approach to hormone therapy and menopause. And then they had to backtrack on that. But a lot of physicians didn't know about that backtrack. Even myself, I didn't know how safe hormones can be. So the North American Menopause Society lists members that get these periodicals, the monthly journal, that might go to conferences. There are also certified practitioners. So that's a different level. That's someone who has taken an exam to proven that they understand this information, and they are responsible for continuing medical education so many hours a year. So I think I have to keep up like 50 hours of medical education in a 3-year time, which I just did 20 hours over the last few days. So, you want to go to somebody who knows what they're talking about. So in the state of North Dakota, we now have 3. So I'm one of them. There's someone in Bismarck, and my partner, Bailey Hansen, just passed her exam on Monday. So we were very happy for her. So North Dakota might have the most menopause practitioners per capita right now in the country.
Good for us.
Not anybody for a long time. So I'm happy there are more people. Obstetrics and gynecologists, they do get quite a bit of education during their training. So if you feel comfortable with them and you feel confident, please go see them. Family medicine providers, they can specialize in different things. So you want to make sure that you ask them, do you feel comfortable with menopause? If not, can you please help me find someone who is? And on the NAMS website, they list those providers who are certified if you want to see them.
Okay. And you said it was which website? NAMS, N-A?
So the North American Menopause Society,
okay.
And it's menopause.org.
Oh, very good. Well, that's awesome. Thank you so much, Dr. McGowan. This was just a pleasure to hear from you today and to talk about this subject that just doesn't get enough attention. And so it was awesome. I want to thank all my colleagues who have helped behind the scenes, Marnie Peel, Janelle Mose, and Wendy Hogue. So thank you very much for joining us for Menopause, What You Actually Need to Know.